Para todos, un gusto, doctor Salgado, muchas gracias. Bueno, por participar en estas jornadas. Me gustaría, antes de que comience, dar una pequeña introducción. La verdad que es un honor y un placer tenerlo como orador en estas jornadas. Muchas gracias nuevamente. Para comentar a la audiencia, el doctor Roberto Salgado es anatomopatólogo certificado desde el año 2006 y trabaja en Bélgica, en Amberes. Es investigador honorario asociado en la División de Investigación del Centro de Cáncer Peter MacCallum en Australia, en Melbourne, además de formar parte del consorcio TracerX, con el objetivo de descifrar la evolución del cáncer en distintas áreas como pulmón y riñón. Y actualmente es copresidente en un consorcio internacional de patólogos, de International Immuno-Oncology Biomarkers Working Group, que tiene un sitio web que invito a todos a ingresar, que la verdad que es sumamente interesante, y supongo que ahora el doctor nos va a comentar un poco al respecto, que desarrolla pautas para la evaluación de biomarcadores en inmunooncología en el cáncer, ¿no? Un tema tan actual para todos los patólogos. No voy a tomar más minutos. Muchísimas gracias, doctor, y lo dejo con su presentación.
Ok, muchas gracias. Voy a tratar de... ¿Cómo puedo compartir mi presentación?
Abajo en el centro hay un botón verde que dice compartir pantalla.
Sí, y sale who can share, and who can start sharing when someone else is sharing. All panelists. Ah, ya, espérate. A ver, y ahora.
Ahí está apareciendo.
Ok. Display settings. ¿Cuál me ven ahora? ¿Ven la presentación?
Sí, se ve.
¿Sí?
¿Ven los slides que se van para arriba y para abajo? ¿Sí? ¿No?
Sí,
Ya,
se ve la presentación.
Ya, ok. Muchas gracias a todos para la invitación.
Se ve la presentación, faltaría que pongas en modo presentación, porque vemos la presentación y a la izquierda las siguientes.
A ver.
Abajo a la derecha hay 1, 2, 3, el cuarto botoncito, creo que es.
Pero ¿y ahora? ¿Lo ven? ¿Ven los slides que se suben y se bajan?
Bueno, sí, sigamos así, se ve bien.
Sí.
Sí, ok. Muchas gracias otra vez para esta invitación. Yo soy chileno. Trabajo en Bélgica hace como 40 años ya. Así que le voy a dar mi presentación en inglés. Pero les invito a hacer todas las preguntas que quieran en castellano. Y voy a tratar de responderla en castellano. Y si no me resulta, voy a cambiar a inglés otra vez. So my lecture will be on implementing tools in daily breast cancer. And I will show you some recent evolutions where the digital pathology can help us implement those tools. These are my disclosures. And this is, first of all, an important concept because this applies to many other different biomarkers. It first starts with the notion of what do pathologists see through their microscope before we move to the digital pathology field. So I'm going to talk about the immune cells in breast cancer. And here you see these small round blue cells, which are called the TILs, which are lymphocytes and plasma cells. And now we know, for example, that if this case would be a patient with triple negative breast cancer, so conceptually the most aggressive breast cancer type that we have, now we do know that these patients will have an excellent outcome. And if this patient would be treated with immunotherapy, we also do know now, and I will show you the evidence in a minute, that these patients will also respond quite favorably to immunotherapy. And here you see the cancer cells, and this is, for example, a case in which...
Disculpe,
¿Sí?
doctor,
¿Sí?
Roberto, disculpe, no se ven las diapositivas.
¿No?
O sea, estamos viendo solamente la diapositiva inicial. No sé si puede ir a la opción de View, quizás ahí
sí,
arriba.
Yo pensaba que estaba puesta. No, así que parece que no. A ver. A ver. Lo que pasa es que tengo 3 pantallas. ¿Y ahora se mueven los slides? ¿Para arriba, para abajo?
No,
No.
por el momento no. Solamente vemos
Abajo dice Notes, abajo a la derecha. El tercero, el cuarto iconito, el que está justo al lado del menos, es el de la presentación.
A ver, 1, 2, 3.
Abajo, abajo a la derecha. Ese.
A ver, no lo veo.
ese.
Espérate. Escape. Siempre complicado esta cosa. Espérate. So, no veo lo que usted me quiere decir.
Abajo de todo, en el pie, a la derecha.
Pero tengo que salir de esto entonces. Espérate.
No, ahí donde estamos viendo.
Ya.
Abajo a la derecha hay dice Notes, y hay 4 iconitos. El cuarto es el de la presentación.
Ya. Otra vez.
Si no, donde dice Slideshow, en el menú.
A ver.
El
Display setting.
menú.
Duplicate slideshow. Ese. A ver. ¿Y ahora?
El primero dice desde el
Ahí está.
beginning.
A ver, ¿y ahora? ¿Y ahora?
Ahora
Ahí
sí.
está, ahí perfecto.
¿Ahora sí?
Sí,
Sí.
excelente. Gracias.
Ok, súper. No, gracias a usted. Voy a empezar de vuelta entonces. Otra vez, muchas gracias por la invitación. Soy chileno, trabajando en Bélgica hace como 40 años. Ustedes pueden hacer todas sus preguntas en castellano, pero como mi castellano científico no es tan excelente, lo voy a hacer en English. Here are my declaration of interest, and I will talk about tumor-infiltrating lymphocytes, which are the immune cells. And this is a very important concept before we move to the digital pathology field. And I will show you that it's extremely important to understand what pathologists see through their microscope before we consider anything on digital pathology. What you can see here is a case of breast cancer. And you can see the immune cells here, small round blue cells, which are called the TILs, lymphocytes and plasma cells, and here are the cancer cells. And now we do know that if this case would be a patient with triple-negative breast cancer, this patient will have an excellent outcome, so a very long survival. I will show you some new evidence on this. And if this patient would be treated with immunotherapy, this would be a patient that will probably respond to immunotherapy, irrespective of what a PD-L1 stain will give. And I will show you the evidence in a minute. And the question is, can digital pathology help us or machine learning tools help us? And here you see the cancer cells. And here you see a case, for example, in which you see the cancer cells here. When you don't see any immune cells, so not one, ni uno, not one single immune cell. And if this patient would be a triple-negative breast cancer case, we now do know, and I will show you the evidence in a minute, that these patients will not do very well in terms of outcome. And if this patient would be treated with immunotherapy, it will probably not respond either. And any PD-L1 stain will be negative in this case. What I'm going to show you in a minute is a set of reflections on this manuscript that we have written a few years ago, because it is a tremendous importance on machine learning applications to assess those immune cells. But first of all, we'll show you the clinical relevance. Why should we do this? Or why should clinicians and pathologists start to think about TILs? So now we do have a tremendous amount of evidence on the prognostic importance of TILs. So the more immune cells you have, the better the outcome. And we have level of evidence 1B, which is nearly the highest level of evidence of TILs as a prognostic biomarker. And now we have discussions with clinicians and many clinical organizations about should we use the TILs in daily practice or not? And many clinicians still feel that TILs should be used as a binary variable, and that's why some of them are quite reluctant to use the TILs as a biomarker in daily practice. And I will argue here that for many of the other prognostic variables that we use in our daily practice for many decades already, like for example, lymphovascular tumor invasion, we don't have level of evidence 1. Lymphovascular tumor invasion is a biomarker with level of evidence 3. So not so high, yet we all use it in our daily practices. And why? Because we use it combined with all the other prognostic variables like tumor size and lymph node status. So that's how the TIL should also be used as a prognostic variable together with all the other prognostic variables. Because has there been prospectively designed biomarker trials for any of the other biomarkers that we use in our daily practices in terms of prognosis? No, it's not. Because most of them have been implemented based on the outcome of the patient and not based on prediction. So for prognosis, TIL should be used together with all the other prognostic variables. And in breast cancer, how should we use it then? And when clinicians discuss with their patients about de-escalation chemotherapy or escalating chemotherapy, they use prognostic variables. So might there be a subset of patients with triple negative breast cancer in which the tumor has a lot of TILs? And would this patient be eligible for less chemotherapy or no chemotherapy at all? So what I will argue in a minute is that TIL should be used together with all the other prognostic variables, age, tumor size, and lymph node status, because there is a subset of patients who do excellent, and I will show you the data in a minute. This is, for example, results from a pooled analysis, and I will come to the digital pathology item in a minute, and in which we have analyzed more than 2,000 patients with triple negative breast cancer in the adjuvant setting. What you see here is that patients with more than 30% of TILs in stage 1B, meaning tumors up to 2 centimeters, grade 3 and lymph node negative, who have more than 30% of TILs have nearly 100% 5-year survival. It's this curve. So these patients today, most of them get already chemotherapy. So this patient, the added value of chemotherapy at the 5 years outcome is probably very limited. So should these patients receive chemotherapy? And the important thing, as I mentioned before, the TIL should be used together with all the other prognostic variables, so not alone. So if you have a patient in front of you with high TILs and that patient is reluctant to receive chemotherapy, the TILs may help you decide de-escalate chemotherapy, but it should not be used as a binary variable. And importantly, if you go to stage 2A, for example, in the TILs, meaning up to 5 centimeters, lymph node positive, those patients with more than 30% of TILs have a better outcome than the small triple negatives. So you can up or downgrade stage according to the levels of the immune cells, according to the levels of the TILs. And the debate is now, can machine learning tools help us? And I will come to that in a minute. And importantly, histological grade is not a prognostic variable in triple negative breast cancer. So clinicians should use conceptually the TILs as a biomarker together with tumor size and lymph node status and not histological grade. Because in triple negative breast cancer, it's the immune system that drives the outcome of the patients and not the cancer cell characteristics. Then we looked at, and this was presented at ESMO this year, the prognostic value of TILs in the very young patient population, meaning very young, younger than 40 years old, triple negative breast cancer who never received systemic chemotherapy, never. And we did find a data set of more than 500 patients with 15 years follow-up, 15. And to make a long story short, if you have a lot of TILs, those patients have at 15 years follow-up, less than 2% distant metastasis, risk of distant metastasis. 15 years follow-up. This suggests again that there might be a subpopulation of triple negative breast cancer based on the strength of the immune system, which may not benefit that much from adjuvant chemotherapy. And today, most of them get chemotherapy. And moving to prediction, a few slides, and then we go to digital pathology discussion. and the initiatives that we are conducting with the working group. The Keynote 119 is a very interesting study, phase 3 study, pembrolizumab versus single agent chemotherapy, metastatic advanced triple-negative breast cancer. The trial was negative using PD-L1 as a biomarker. And what you see here is that if you have more than 5% of TILs, it's the blue curve, those patients have an excellent overall survival benefit. And remember, with PD-L1, it was negative. But if you look at the TILs, you do find an overall survival benefit. And if you don't have TIL, which is the gray line here, those patients do not benefit at all. And in the middle, you see the chemotherapy arms. So this is a phase 3 trial showing that TILs predict overall survival. So we have shown already that TILs predict benefit as a prognostic variable, and this suggests, this data, that TILs as a predictive variable predict overall survival in patients with triple-negative breast cancer receiving immunotherapy. Moving further to the Impassion 130 study, which was led to the first approval of atezolizumab in triple-negative breast cancer, which was not confirmed in another study, the Impassion 131, so it was withdrawn by Genentech. And in this study, they also looked at the TILs. And if you look at this recent publication, here you see the overall survival benefit if you have TILs compared to if you don't have that many TILs receiving atezolizumab and chemotherapy. And you see that there is an overall survival benefit. And if you look at the hazard ratios of PD-L1 positivity and TILs, and whatever way you look at it, you do find the same hazard ratios of benefit. And so this suggests that the TILs give you the same information on prediction to immunotherapy as PD-L1. And we all know the difficulties of PD-L1 assays in our daily practices. So the TILs may inform clinicians and pathologists about the PD-L1 status. So considering Keynote 119 and Impassion, both of them prospectively designed phase 3 trials, both of them showing that TILs predict benefit to immunotherapy, I do think that the TILs as a predictive factor of level 1B, but for prediction, you need a binary variable. And for that, you need level of evidence 1A. So should we use the TILs in our daily practices for prediction? Probably not, because the major evidence was with PD-L1, but the TILs can help. So the new framework, and then slowly getting into the digital pathology field, the TILs can be assessed in a reproducible manner. Is it a perfect variable or not? It is not perfect because it's morphology. And there has been this quote about whether we should use digital pathology to have a more accurate assessment of those TILs between pathologists. And does it matter? And I will explain in a minute that it may not matter that much. We just need a microscope and an H&E, or a software tool, maybe. When we make a diagnosis of TILs at the diagnosis in the adjuvant setting, we do know that if you have a very early stage with high TILs, you do excellent. We also do know that TILs and PD-L1 are associated with prediction to immunotherapy. So if pathologists code the TILs in their daily practice for prognostic purposes in the adjuvant setting, this information is already present in the report of the patient when the patient develops metastasis many years later, where you might give her immunotherapy, pembro, or in some settings still atezol. So I do believe that pathologists can use PD-L1, any PD-L1 assay, as long as it is well validated, but together with the TILs. Because if you don't have TILs, any PD-L1 assay will be negative. And if you have many TILs, every PD-L1 assay will be positive, most of them. Now, the question is how do you implement computational assessment of TILs? It's emerging in daily practices worldwide, bit by bit. And we are not industry, we are academia. So there are very different ways to score the TILs, and the narratives of TILs apply to all biomarkers, ER, PR, histological grade, lymphovascular tumor invasion, mitotic activity, etc. So with everything I'm going to tell you now can apply also to other biomarkers. The first question is, should a computational follow the internationally accepted method that has clinical validity? So with pathologists, we have developed this guideline to score the TILs in breast cancer. And it's now being applied in many other tumor types using morphology, using a microscope. And we have proven the clinical validity, and we will prove the clinical utility in the next years. Should a software tool to assess the TILs follow the same guideline? And we have two types of machine learning tools on TILs. Some apply the guidelines and actually replicate the guidelines, and others do not replicate the guidelines. Does it matter? Is there a ground truth in digital pathology? There is this claim that artificial intelligence method or machine learning methods are more accurate than pathologists to score the TILs. We will release data, hopefully soon, in which we have compared very few different machine learning tools, and the variability which you see is actually the same variability as you would see between different pathologists. Because the same biases and the same items that are difficult for us pathologists to recognize on H&E slides are also difficult for machine learning tools. For example, lymphocyte aggregates. We, in the guideline that we have developed, we say that you should not consider them as TILs, but the machine learning method will recognize these as TILs and will count them. So you get an inflation of TILs. And there are many other examples. For example, we do not assess the immune cells in DCIS, in pre-invasive cancer, in the method that we have developed. Yes, some machine learning tools can distinguish the TILs with invasive cancer with the TILs with non-invasive cancer, and while others don't. Is this important, yes or no? We will release data in the next months showing that the concordance between pathologists and the machine learning tool to assess the TILs is not so good for the reasons I just explained. But we have shown in at least 4 different phase 3 trials, and we will present the data hopefully next year, that both of them predict outcome in the same manner. So whether you score the TILs using the computer or whether you score the TILs manually, and whether the concordance between both of them, the pathologist and the machine learning tool, is not excellent, in terms of outcome, both predict the same information. So the golden standard might be outcome and not the concordance between the pathologist and the digital tool. And this applies probably to all the other biomarkers that we might assess using digital tools. How should we report the TILs? We now, morphologically speaking, in our daily practices, in most of our daily practices, we assess the TILs and we report the TILs using a percentage, one number, 50% of TILs, 40% of TILs, that's it. With digital tools, you have a lot of different variables that you can assess. This is a report, for example, proposed by us, the working group, in which you have all these different variables. The distance from the TIL to the cancer, the distance from the TIL clusters per unit area, the morphology, the size, etc. All things that we cannot assess using a microscope, but a machine learning tool can easily do this. Is this important? Yes or no? And why? And should clinicians use this information? Clinicians want in their daily practices very easy information, binary information, positive, negative, presence, absence. Imagine your clinician if you would give such a report to him. He will call you and say, what do I have to do with all this information? And that's a rightful answer. So can we define the ground truth? I start to believe, based on the evidence, which you will see early next year, probably at ASCO, some of them, that the ground truth is probably outcome and not the concordance with the pathologist. How can we ensure reliable integration in our daily practices of the TILs? How should we report the TILs? And this is something that we need to understand first, based on the publicly available data on the ground truth, before we start to think of this. For many years, we have already been working with many organizations, including the US FDA, on TILs, and I will show you some examples that we are currently developing. This, for example, is a project that will be public very soon, in the next weeks. So as I explained, the concordance between pathologist and the machine learning tool is not so excellent because the outcome is similar. but does this apply to all machine learning tools? So what we are releasing in the next weeks is a public challenge. So we have developed a platform in which we will host a phase 3 clinical trial, in which we have scored the TILs. And this clinical trial, 940 slides, H&E full slides will be on the platform. And we will invite the community, the whole community. If you think you have a validated machine learning tool to score the TILs, please upload it on the platform. We will run the algorithm on all those slides. We will collect the data and we will see, does it predict outcome in the same manner as the manually scored TILs? And we will be able to compare all the different machine learning tools that have all been developed in a different way. So that maybe we can start to develop, based on this data, reference materials to score the TILs. Because my main concern in digital pathology is if my hospital would use a machine learning tool to score the TILs, or for Kia67, or for GRADE, or ER, estrogen receptor, and the hospital across the street will use a different one, a different machine learning tool, or a different digital pathology, we will probably be discordant, as we would be discordant between pathologists. So how can we avoid this? By using and developing reference materials. So with the FDA and many other partners, for example, Emory University, but many other partners, we are developing an important project on reference materials for TILs, because pathologists were very good at to recognize cells, but we are not so good at quantitation. And this project is ongoing, and you will see the first data of this first quarter next year. So the aim of this project is very simple. We will develop reference materials, we will make them public, and the FDA is going to use these reference materials to see whether a machine learning tool can get a regulatory approval or not. So if you, for example, have a machine learning tool to score the TILs and you want to get an FDA approval, the FDA will tell you, apply it first using the reference materials and send us your data. Because FDA has the data on those reference materials and they will be able to judge your machine learning tool in a very accurate manner using those reference materials. And I think that would be a tremendous breakthrough in academic regulatory partnerships by developing reference materials that can be used by the community to apply for regulatory approval for machine learning tools. Oops. Here we go in terms of measures. So this is an important project with which is being led by Brandon Gallas, as a mathematician, with a tremendous amount of partners, and we have developed a platform to do this, and this platform will also be used to collect data and to develop those reference materials. And that's us. In conclusion, what I explained to you for the moment has been a collaborative effort between all stakeholders: industry, patients, regulatory, and the academia. And we should also pursue this partnership for machine learning applications. And we need to avoid monopoly positions by industry or by academic groups. And the way that we are developing these partnerships, I do think it's exemplary for a lot of other work being done in the academic community. Voilà. Esta era mi última slide. Muchas gracias por su atención. Estoy abierto para todas las preguntas. Por favor, hágalo en castellano. Y si iba a tratar de responder en castellano también. Muchas gracias.
Muchas gracias, doctor, por su presentación. Bueno, muy interesante. No sé si los participantes tienen alguna pregunta para hacer. Tenemos pocos minutos, pero bueno, aprovechar este momento.
Sí, perdimos un poco de tiempo con al inicio.
No, sí, no hay problema.
A ver en el chat.
Creo que no.
No.
No, el chat ya estuve mirando yo.
Bueno.
Ok. Quizá pueda era en inglés. Yo doy este tipo de charla muchas veces y a veces hay traducción simultánea para en Asia, por ejemplo. Mis slides se pueden distribuir.
Bueno, bárbaro.
La gente que quiere recibir, me mandan un mail y yo sería un placer compartir mis slides. Si tienen preguntas, por favor, no duden en contactarme. Los TILs se están poniendo extremadamente importantes, no solamente en cáncer de mama, en cáncer del pulmón, el siguiente, en cáncer de head and neck, el siguiente también, el cáncer colorectal, porque es simple, miras el microscopio, eso es todo. Pero lo importante de mi presentación es que la patología digital no va a solucionar todos los problemas de los patólogos. Eso lo tenemos muy claro ahora con los datos que hemos obtenido en esos ensayos clínicos fase 3. Hay que mirar adelante del hype de Machine Learning.
Y doctor, yo tenía una pregunta para hacerle, si tiene experiencia digamos, en el conteo, en el porcentaje de PDL1 en inmunistoquímica a través también de, bueno, de la digitalización o de algún algoritmo de Machine Learning.
Sí, muy complicado. La experiencia que tengo hasta ahora, que es muy breve, muy poco, es muy complicado, porque primero el PDL1 no ves un staining que es muy limpio. Muy difícil interpretarlo porque no se sabe bien cuáles son las células. Se ve algo café por ahí. Y segundo, estamos haciendo un proyecto que va a durar 6 a 9 meses en que hemos hecho un PDL1 por los 3 anticuerpos. 22C3, SP142 y SP263. Como 70 pacientes, y vamos a aplicar Machine Learning en todos los 3. Los 75 pacientes que están eso con los 3 anticuerpos. Y vamos a ver lo que pasa. No tengo idea si es posible desarrollar un ensayo de Machine Learning para PDL1 en patología digital. Mi experiencia hasta ahora es que no es tan fácil y vamos a ver lo que va a pasar. Y los datos van a ser públicos también, una vez que terminamos ese ejercicio. Pero hasta ahora, yo sé que Visiofarm tiene un Machine Learning Tool que lo vamos a empezar a testar en un par de semanas. Pero hasta ahora no estoy tan convencido que hay uno que realmente es superior a todos los otros.
Bueno, muchas gracias.
¿Y qué piensa usted?
No, en realidad nosotros estamos un poco lejos todavía digamos, de todo lo que usted nos contó y han desarrollado. Vamos a conseguir ahora unos escáneres y bueno, teníamos ganas de implementar algún algoritmo, sobre todo en técnicas de inmunistoquímica como PDL1 o Ki67, que como usted dijo, los patólogos digamos, identificamos, pero nos cuesta la parte de cuantificar, ¿no? Entonces, pero bueno, estamos muy verdes con eso y teníamos pensado, digamos, o la idea era, uno de los objetivos era con PDL1, pero quería ver su experiencia, pero bueno, si nos dijo que lo ve complicado.
Sí, es complicado, pero vale la pena, pero es complicado. PDL1 es uno de los más difíciles, creo que, para desarrollar. Creo que mejor empezar con ERPR, por ejemplo.
Bien, claro, sí, receptores o Ki67. Exacto.
O los TILs, como quieran.